Hello, everybody. This is the continuation lecture of heart failure of 2021 guidelines of heart failure. So, the diagnosis of heart failure with reduced ejection fraction. The heart failure with diagnosis of heart failure with reduced ejection fraction requires the presence of symptoms and signs of heart failure and reduced ejection fraction, that is, ejection fraction of less than 40%. This is most commonly obtained by the echocardiography. If assessment of the ejection fraction is not possible by echocardiography, then the cardiac magnetic resonance, rarely nuclear techniques can be employed. Pharmacological treatment for patient with heart failure with reduced ejection fraction. The goals for pharmacotherapy for patient with heart failure with reduced ejection fraction. There are three major goals for treatment of the patient with heart failure with reduced ejection fraction. Reduction in mortality, prevention of recurrent hospitalization due to worsening heart failure, and improvement in clinical status, functional capacity, and quality of life. General principle of pharmacotherapy for heart failure with reduced ejection fraction. Modulation of renin-angiotensin-aldosterone and sympathetic nervous system with angiotensin converting enzyme inhibitor and angiotensin receptor neprilysin inhibitor, beta blocker, mineralocorticoid receptor antagonist has been shown to improve survival, reduce the risk of heart failure hospitalization, and reduce the symptom in patient with heart failure with reduced ejection fraction. These drugs served as foundation of the pharmacotherapy for patients with heart failure with reduced ejection fraction. A triad of SE inhibitor, ARNI, beta blocker, and MRA is recommended as cornerstone therapies for these patients unless the drugs are contraindicated and not tolerated. They should be uptitrated to the doses used in the clinical trial. The guideline still recommends the use of ARNI as a replacement for ACE in suitable patients who remain symptomatic on ACE, beta blocker, and MRA therapies. However, ARNI may be considered as a first-line therapy instead of ACE. The recommended doses of the drugs we'll discuss subsequently. Angiotensin receptor blockers still have role in those who are intolerant to ACE and ARNI. Now, the SGLT2 inhibitors like dapagliflozin, empagliflozin added to therapy with AC, ARNI, and beta blocker MRA reduce the risk of cardiovascular death and worsening heart failure in patients with heart failure with reduced ejection fraction. Unless contraindicated or not tolerated, dapagliflozin and empagliflozin are recommended for all patients with heart failure with reduced ejection fraction already treated with AC, ARNI, beta blocker, and MRA, regardless of whether they have diabetes or not. So, management of heart failure with reduced ejection fraction. So, we need to start with AC, ARNI, beta blocker, MRA, dapagliflozin, empagliflozin, and loop diuretics. So, if the patient, this has a class 1 recommendation, so we need to, and then according to the ejection fraction, if the, and this the QRS complex, we need to further classify the therapy. If ejection fraction is less than 30% and the QRS duration is less than 130, then we need to go for the ICD. If the patient is having sinus rhythm, ejection fraction less than 30%, duration of the QRS is more than 130, then we need to go for the CRT. If the for CR if the QRS complex is between 130 to 149, then the CRT has a class 2A recommendation, and if the QRS complex is more than 150, then the CRT has a class 1 recommendation. If ejection fraction is more than 35 or device therapy is not recommended or inappropriate and symptom persists, then consider therapies with the class 2 recommendations. So drugs recommended in all patients with heart failure with reduced ejection fraction. And AC is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. Beta blocker is recommended for patients with stable heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. MRA is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of hospitalization and death. Dapagliflozin and empagliflozin are recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. All of this treatment has a class of recommendation 1 level of evidence A. Sacubitril valsartan is recommended as a replacement for AC in patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. This has a class of recommendation 1 level of evidence B. Now, this is the evidence-based doses of disease-modifying drugs in randomized trial that has been used in patients with heart failure with reduced ejection fraction. So AC in AC class, it includes captopril, enalapril, lisinopril, ramipril, and trazodone. So most commonly used is captopril. The starting dose is 6.25 mg, target dose is 50 mg. Enalapril, the most starting dose is 2.5 mg, targeted dose is 10 to 20 mg. Lisinopril 2.5 to 5 mg, targeted dose is 20 to 25 mg. Ramipril, the targeted dose is 2.5 mg BD and the targeted dose is 5 mg BD. Trandolapril, the starting dose is 0.5 mg OD and the target dose is 4 mg. Then Arni, sacubitril valsartan, the starting dose is 49 to 51 mg, targeted dose is 97, 103 mg. Then beta blocker, bisoprolol 1.25 mg OD, target dose is 10 mg. Carvedilol 3.125 mg BD, target dose is 25 mg. Metoprolol targeted starting dose is 12.5 to 25 mg OD, target dose is 200 mg. Nebivolol target dose starting dose is 1.25 mg OD, target dose is 10 mg. Then mineralocorticoid receptor antagonist, eplerenone and spironolactone. Starting dose is 25 mg, target dose is 50 mg. Spironolactone starting dose is 25 mg, target dose is 50 mg. Then SGLT2 inhibitor, dapagliflozin 10 mg, empagliflozin 10 mg. And the other drugs that can be used is candesartan in the dose of 4 mg, then losartan 50 mg OD, valsartan 40 mg BD, ivabradine 5 mg BD, vericiguat 2.5 mg OD, then hydralazine 37.5 mg TID. Now the first class is angiotensin converting enzyme inhibitor, AC, for the first class of drugs shown to reduce mortality and morbidity. They have also shown to improve symptoms. They are recommended in all patients unless contraindicated and not tolerated. They should be up-titrated to maximum tolerated recommended doses. Now, the beta blocker have been shown to reduce mortality and morbidity in patients with heart failure with reduced ejection fraction, in addition to the treatment of AC. They also improve symptoms. There is consensus that AC and beta blocker can be commenced as soon as the diagnosis of symptomatic heart failure with reduced ejection fraction is established. There is no evidence favoring the initiation of beta blocker before AC and vice versa. Beta blocker should be initiated in clinically stable euvolemic and patient at low dose, gradually up-titrated to the maximum tolerated dose. In patient admitted with the acute heart failure, beta blocker should be cautiously initiated in hospital once the patient is hemodynamically stabilized. Individual patient data, meta-analysis of all major beta blocker trials in heart failure with reduced ejection fraction had shown no benefit on hospital admission and mortality in subgroup of patients with heart failure with reduced ejection fraction and with atrial fibrillation. However, since this is retrospective subgroup analysis and because beta blocker did not increase risk, guideline committee decided not to make the separate recommendation according to heart rhythm. Mineralocorticoid receptor antagonists like spironolactone and eplerenone are recommended in addition to AC inhibitor and beta blocker in all patients with heart failure with reduced ejection fraction to reduce mortality and risk of heart failure hospitalization. They also improve symptoms. MRA block the receptor that bind aldosterone and with different degree of affinity, the other steroid hormone receptor. Eplerenone is more specific for aldosterone blockage and therefore cause less gynecomastia. Caution should be exercised when MRA are used in patients with impaired renal function and in those with serum potassium concentration more than 5. Now the angiotensin receptor neprilysin inhibitor. In the paradigm heart failure trial, sacubitril valsartan and arnim was shown to be superior to enalapril in reducing hospitalization for worsening heart failure, cardiovascular mortality, and all-cause mortality in patients with ambulatory heart failure with reduced ejection fraction, with ejection fraction of less than 40%. Addition benefit of sacubitril valsartan included improvement in symptoms and quality of life, and reduction in incidence of diabetes requiring insulin treatment, reduction in decline in EGFR, as well as reduced rate of hyperkalemia. And additionally, the use of sacubitril valsartan may allow reduction in diuretic requirement. Symptomatic hypotension was reported more commonly in patients treated with sacubitril valsartan as compared to enalapril, but despite developing hypotension, these patients also gained clinical benefit from sacubitril valsartan therapy. Therefore, it is recommended that AC and ARB are replaced by sacubitril valsartan in ambulatory patients with heart failure with reduced ejection fraction who remain symptomatic despite optimal treatment. Two studies have examined the use of ARNI in hospitalized patients, some of whom had not been previously treated with AC. Initiation in this setting appears safe and reduce the subsequent cardiovascular death and heart failure hospitalization by 42% compared to another. As such, initiation of sacubitril valsartan in AC patient with the heart failure with reduced ejection fraction may be considered. It has a class of recommendation 2B level of evidence B. Patient being treated on sacubitril valsartan should have adequate blood pressure and EGFR should be more than 13. Washout period of at least 36 hours after ACE therapy is required in order to minimize risk of anxiety. Then SGLT2 inhibitor. DAPA heart failure trial investigated the long-term effect of dapagliflozin compared to placebo in addition to optimum real medical therapy on morbidity and mortality in patients with ambulatory heart failure with reduced ejection fraction. Therapy with dapagliflozin resulted in 26% reduction in primary endpoint composite of worsening heart failure and cardiovascular death. Both of these components were significantly reduced. Moreover, dapagliflozin reduces all-cause mortality, elevated heart failure symptom, improved physical function and quality of life in patients with symptomatic heart failure with reduced ejection fraction. Benefits were seen early after initiation of dapagliflozin, and the absolute risk of reduction was large. Survival benefits were seen to same extent in patients with heart failure with reduced ejection fraction, with or without diabetes, and across the whole spectrum of HbA1c values. Subsequently, the Emperor reduced trial found that empagliflozin reduces the combined primary endpoint of cardiovascular death in the heart failure hospitalization by 25% in patients with NYHA class 4 symptom and heart failure with an ejection fraction of 20%. There was also reduction in the decline in EGFR in individuals receiving empagliflozin. It was also associated with improvement in quality of life. Therefore, dapagliflozin and empagliflozin are recommended in addition to optimum medical therapy in patients with AC, ARNI, beta blocker, and MRA for patients with heart failure with reduced ejection fraction, regardless of diabetes status. The drug reduces the cardiovascular death and hospitalization. Therapy with SGLT2 inhibitor may increase the risk of recurrent genital function, genital fungal infection. Loop diuretics are recommended to reduce the signs and symptoms of congestion. Loop diuretic produces more intense and shorter diuresis than thiazide. They act synergistically and the combination may be used to treat diuretic resistance. However, adverse effects are more likely and this combination should only be used with care. ARNI, MRA, and SGLT2 inhibitor also possess diuretic property. Now, the angiotensin 2 type 1 receptor blocker. They are recommended for patients who cannot tolerate AC and ARNI. Candesartan is the in the charm alternative study reduced the CV death and heart failure hospitalization patients who were not receiving AC due to previous intolerance. Valsartan, in addition to usual therapy, including AC and reduced heart failure hospitalization in the VALT HEFT trial. However, no ARB has reduced all-cause mortality in any trial. Combination of the hydrolysine and isosorbate dinitrate. Additionally, the combination of hydrolysine and isosorbate dinitrate may be considered in symptomatic patients with heart failure with reduced ejection fraction who cannot tolerate any of AC, RNA, and ARB to reduce the mortality. Digoxin may be considered in patients with heart failure with reduced ejection fraction in sinus rhythm to reduce the risk of hospitalization, although its effect on those routinely treated with beta blocker has not been tested. In the DIC trial, the overall effect on mortality with digoxin was neutral. In patients with symptomatic heart failure and atrial fibrillation, digoxin may be useful for treatment of patients with heart failure with reduced ejection fraction and atrial fibrillation with rapid ventricular rate when other therapeutic option cannot be pursued. Digoxin has narrow therapeutic window and so the level should be checked, aiming for serum digoxin concentration less than 1.2. Caution should be exercised when using it in female, the elderly, frail, hypokalemic, and malnourished subject. In patients with reduced renal function, digoxin could be considered. Digoxin use in heart failure and sinus rhythm is currently being investigated. Then soluble guanylate cyclase receptor stimulator. The Victoria study assessed the efficacy and safety of oral soluble guanylate cyclase receptor stimulator, vericiguat, in patients with reduced ejection fraction and recent decompensated CH. There was no reduction in either all-cause and the CV mortality. Thus, vericiguat may be considered in addition to standard treatment to reduce the risk of CV mortality and hospitalization. Now, the cardiac myosin activator. Galactic Heart Failure Study assessed the efficacy and safety of cardiac myosin activator, omecamtiv mecarbil, in heart failure with reduced ejection fraction patients, enrolling patients in both inpatient and outpatient setting. The primary endpoint of the first heart failure event and CV death reduced by 8%. There was no significant reduction in CV mortality. So the other drug recommendation ought to be considered in selected patients with heart failure with reduced ejection fraction. So diuretics are recommended in patients with heart failure with reduced ejection fraction with signs and symptoms of congestion to elevate heart failure symptoms, improve exercise capacity, and to reduce the heart failure hospitalization. This statement has a class of recommendation 1 level of evidence. An ARB is recommended to reduce the risk of heart failure, hospitalization, and cardiovascular death in symptomatic patients unable to tolerate ACA or RNA. This statement is class of recommendation 1, level of evidence B. Then avabradine should be considered in symptomatic patients with ejection fraction less than 30 or equal to 35% in sinus rhythm and resting heart rate of more than 70. Despite treatment with evidence-based dose of beta blocker, AC, MRA to reduce the risk of heart failure, hospitalization, and CV death. This is class of recommendation 2A, level of evidence B. Ivabradine should be considered in symptomatic patient with ejection fraction less than 35% in sinus rhythm, resting heart rate more than 70, who are unable to tolerate or contraindicated to the AC inhibitor ARNI, and patients should also receive AC, RNA, and MRA. This has class of recommendation 2A, level of evidence C. Then vericiguat may be considered in patients with NYHA class 3-4 who have worsening heart failure despite treatment with ACE, ARNI, beta blocker, MRA to reduce the risk of CV mortality and heart failure hospitalization. Class of recommendation 2B, level of evidence B. Hydralazine isosorbate dinitrate should be considered in self-identified Black patients with ejection fraction less than 35 or ejection fraction of less than 45 combined with dilated left ventricle In NYHA class 3-4, despite treatment with AC or ARNI, beta blocker and MRA, to reduce the risk of heart failure, hospitalization, and death. This has class of recommendation 2A, level of evidence B. Hydralazine isosorbate dinitrate may be considered in patients with symptomatic heart failure with reduced ejection fraction who cannot tolerate any of the AC, ARB, and RNA to reduce the risk of death. Class of recommendation 2B, level of evidence B. Digoxin may be considered in patients with symptomatic heart failure with reduced ejection fraction in sinus rhythm, despite treatment with AC or a beta blocker MRA to reduce the risk of hospitalization. Class of recommendation 2B, level of evidence B. Cardiac rhythm management for heart failure with reduced ejection fraction. The use of ICD and CRT. Implantable cardioverter defibrillator. The high proportion of death among patients with heart failure, especially those with milder symptoms, occur suddenly and unexpectedly. Many of these may be due to electrical disturbances, including ventricular arrhythmia, bradycardia, asystole, although some are due to the other acute vascular event. Treatment that improve or delay the progression of cardiovascular disease have been shown to reduce the annual rate of sudden death, but they do not treat the arrhythmic event when they occur. ICDs are effective at correcting potentially lethal ventricular arrhythmia in case of transvenous cysteine, also prevent the bradycardia. The secondary prevention of sudden cardiac death. Compared with the amiodarone treatment, ICD reduce the mortality in survivor of cardiac arrest and in patients who have experienced sustained symptomatic ventricular arrhythmia. An ICD is recommended in such a patient when the intent is to increase survival. The decision to implant should take into account the patient's view and their quality of life. The ejection fraction and survival benefit is uncertain when ejection fraction is more than 35%, and the absence of other disease likely to cause death within the following year. In the Danish trial, the rate of sudden death were low in patients with non-ischemic cardiomyopathy. While there was modest absolute reduction in sudden death with defibrillator containing device, this did not significantly improve overall risk of mortality. On average, the patient with IHD, they are at greater risk of sudden death than patient with non-ischemic cardiomyopathy. Therefore, although the relative benefits are similar, the absolute benefit is greater in patient with IHD. 2-RCT showed no benefit in patient who had ICD implanted within 40 days after MI, although sudden arrhythmic death were reduced. This was balanced by increase in non-arrhythmic death. Accordingly, an ICD for primary prevention is contraindicated in this time period. Furthermore, the ICD implantation is recommended only if minimum of 3 months of OMT has failed to increase the ejection fraction to more than 35%. OMTs ideally include the class 1 recommended drug for heart failure with reduced ejection fraction. However, the ICD trials we cite predate the use of ARNI and SGLT2 inhibitor. Whether implantation of ICD reduced the mortality in those with ejection fraction more than 35% is unknown. There is ongoing trial of ICD therapy in such a patient with presence of scar on ICMR image. Now, recommendation for implantable cardioverter defibrillator. An ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive for more than 1 year with good functioning status in the absence of reversible cause and unless ventricular arrhythmia has occurred in less than 48 hours after MI. Class of recommendation 1, level of evidence A. ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure of an ischemic etiology left with ventricular ejection fraction less than 35% despite more than or equal to 3 months of OMT, provided they are expected to survive substantially longer than 1 year. Class of recommendation 1, level of evidence A. ICD should be considered to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure of non-ischemic etiology and with ejection fraction of less than 35, despite more than 3 months of optimal medical therapy, provided they are expected to survive substantially longer than 1. Class of recommendation 2A, level of evidence A. Patients should be carefully evaluated by an experienced cardiologist before generator placement because management goal and the patient need and clinical status may have changed. Class of recommendation 2A, level of evidence B. Variable ICD may be considered for patients with heart failure who are at risk of sudden cardiac death for limited period or as a bridge to implantable device. Class of recommendation 2A, level of evidence. ICD implantation is not recommended within the 40 days of MI as implantation at this time does not improve prognosis. Class of recommendation 3, level of evidence A. ICD therapy is not recommended in patients with NYHA class 4 with severe symptom refractory to the pharmacological therapy unless they are candidate for CRT, ventricular assist device, and cardiac transplantation. Class of recommendation 3, level of evidence C. Several studies have shown that patients with LBB are more likely to respond favorably to CRT, whereas there is less certainty about a patient with non-LBB morphology. The ECO-CRT trial and IPD meta-analysis suggests possible harm from CRT when QRS duration is less than 1 third. If patient scheduled to receive ICD and is in sinus rhythm with LBB, CRT should be considered if QRS duration is between 130 to 140 and is recommended if QRS is more than 150. Most studies of CRT have specified that ejection fraction should be less than 35%, but RAFT and MALDI CRT specified ejection fraction should be less than 30%, and reverse specified 40%, and block heart failure specified less than 50%. Now, recommendation for CRT. CRT is recommended for symptomatic patient with heart failure in sinus rhythm with QRS duration of more than or equal to 150 and LBB QRS morphology and ejection fraction less than 35 despite OMT in order to improve symptom to reduce morbidity and mortality. Class of recommendation 1, level of evidence A. CRT rather than RV pacing is recommended for patients with heart failure with reduced ejection fraction, regardless of NYHA class and QRS width who had indication for ventricular pacing for high degree AV block in order to reduce mortality. Class of recommendation 1, level of evidence A. CRT should be considered for symptomatic patient with heart failure in sinus rhythm with QRS duration of more than 150 in non-LBB QRS morphology with ejection fraction less than 35% despite OMT in order to improve symptom and reduce morbidity and mortality. Class of recommendation 2A, level of evidence B. CRT should be considered for symptomatic patient with heart failure in sinus rhythm and QRS duration of 130 to 149. QRS, LBB QRS morphology and ejection fraction less than 35 despite oral medical therapy in order to improve symptom, reduce morbidity and mortality. Class of recommendation 2A, level of evidence B. Patient with ejection fraction less than 35% who have received conventional pacemaker or ICD subsequently develop worsening heart failure despite OMT and who have significant proportion of RV pacing should be considered to or upgrade to CRT. Class of recommendation 2A, level of evidence B. CRT may be considered for symptomatic patient with heart failure in sinus rhythm with QRS duration between 130 to 149, non-LBB QRS morphology with ejection fraction less than 35% despite OMT in order to improve symptom, reduce morbidity and mortality. Class of recommendation 2B, level of evidence B. CRT is not recommended in patients with QRS duration less than 130 who do not have indication for pacing due to high degree AV block. Class of recommendation 3, level of evidence A. Now, management of heart failure with reduced ejection fraction. To reduce the mortality for all patients, there are 4 drugs like AC, ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 to reduce hospitalization and mortality and to tackle with volume overload diuretics. Then after optimization, if the after starting this, even if the patient's ejection fraction is not improving, then we need to go for the further management that depends upon the duration of the QRS. If it is a LBB morphology, then CRT. If it is non-LBB, then ICD. Then if it is a ischemic etiology, if it is atrial fibrillation, then anticoagulation. Coronary artery disease, go for CABG. Iron deficiency, correct the causes. If the cause is iron deficiency, correct the underlying iron deficiency. In case of valvular disorder, go for TAVI and SAVR. Mitral regurgitation, mitral valve repair. Then ACA tolerance, go for the R. Then for selected patient, we can plan the heart transplantation, mechanical circulatory device, and long-term mechanical circulatory device. Thank you, guys.